All right, we're now going to embark into the treatment protocols for Cox technique. There are two main treatment protocols, Protocol 1 and Protocol 2. Today we'll be discussing Protocol 1. So who goes where? Which type of patient goes into which protocol? It's very simple. If the lumbar spine disorder that the patient presents with has a radicular component to it, they go into Protocol 1. Regardless of the condition, whether it's disc related, whether it is a spondylolisthesis, whether it is spinal stenosis, whether it is degenerative disc issue, if there is a radicular component associated with it, so in other words, if they have a sciatic leg along with the condition, they go into Protocol 1. Generally speaking, these will be the most painful back conditions or the patients in the greatest amount of pain that you will be seeing. Protocol 1 is the application of 3 20-second decompression sessions. And each session consists of 5 4-second pumps, 2 down and 2 up. Some important points to remember or consider. You always contact the spinous process of the vertebrae superior to the involved disc. We'll elaborate on that in a slide or two. Your contact arm is always straight up the y-axis of the spine. You don't want it to be angled to the right or to the left, just straight up the spine. You always use equal scissors force type of movement. So you have a contact hand and a tiller bar hand, and they apply an equal amount of force like a scissor. And you always take the segment to the barrier of elastic resistance before starting the treatment. And then no other movement except for flexion decompression is introduced until the patient is at least 50% improved. Again, this is a gentle technique. There is not a lot of excursion to the caudal section of the table. Once you've reached the barrier of elastic resistance, the table will descend approximately 2 inches, but this is something that you will learn to feel as you become adept at perceiving tissue tension. It's a skill that'll take time to develop. And then the line of drive. Again, I'll mention for about 99% of the procedures, the line of drive is 2/3 I to S, 1/3 P to A. So predominantly I to S with a little P to A. Okay, so once you have diagnosed the disc level, you then will know which spinous process to contact. And it's a one-on-one pattern consistent throughout the whole spine, literally from C2, which is where we have the first intervertebral disc, all the way down to L5. So if they have an L5 disc, right, let's show you what we're talking about. If they have an L5 disc, and I'll just put a red mark on it right there, kind of where the nucleus is. If they have an L5 disc, in order to create decompression between the L5 vertebrae, and in this case the sacrum, we would have to get on the L5 spinous process, and that would create decompression to the L5 disc. That pattern is consistent throughout the spine. Once you find the disc level, you know which vertebrae to get on. So if it was an L1 disc, in order to get decompression of that disc, we would have to get on the L1 spinous process. Typically, we get on the inferior aspect of the spinous process. So we do our best when taking our tissue pull to get on the inferior aspect of the spinous process. All right, so we mentioned that Protocol 1 consists of 3 20-second decompressions. Between those decompression sessions, the patient will likely need just a little break. Even though you're doing the process or the procedure to their tolerance level, they're still in a lot of pain and you're still stirring the pot, even though you're within their tolerable range. It's good to give them a minute or 2 or 3 minutes to rebound from the decompression. And while you're doing that, what Dr. Cox recommends is that you do some trigger point therapy, particularly on the involved side musculature. So if it was we'll just say a right posterolateral disc protrusion, the patient is probably going to have a centralized pain with a little dominance to the right side. So you would check the erector spinae and the quadratus lumborum on the right side, work down to the glute max and feel under the max for the piriformis and the gemelli muscles, and work down into the hamstrings and the popliteus and the gastrocs. And if you feel a trigger point, just stay on it for a few seconds and gently work it out. Try and get some of the spasm out of the muscles related to the sciatic leg, just to give the patient a break from the decompression and also do something to assist in the healing process. This is also an appropriate time, if done properly, and I say that with caution, if done properly, to use light force instrument adjusting. And when I say light force, I'm talking about an activator on one ring or an arthrostim set at a very, very light level. We try and stimulate the mechanoreceptors in and around the functional spinal unit where the disc lesion is, to try and get some of the spasm and tension in the muscles to release. At the end of the third decompression session, if you're utilizing physiologic therapeutics in your office, this would be the time to introduce them. We recommend high volt galvanic or interferential. Both reduce spasm and edema through increasing cellular permeability, and they give a little bump in endorphins as well. But it's typically a 4-pad therapy. You build about a 4-inch box around the level where the disc lesion is, and you set it for 20 to 30 minutes, and then you can apply ice or heat over the affected area, right over the electrode pads. If there's a lot of edema, avoid heat, use ice. If there's not so much edema but a lot of spasm, use heat. Patient management tip. We try and give you a few of these, and we have gone over this before, but let's reiterate. In order to have success on these difficult disc cases, treatment needs to be administered on a daily basis. It is essential that you make clear to the patient the importance of daily treatment. As a matter of fact, it would be better not to accept a patient who just wants to come in sporadically and give chiropractic a quote, end quote, try. If after 30 days there's no subjective or objective improvement, it is then time to get imaging. Typically, the gold standard of imaging is the MRI. I suggest you hook up with a reputable imaging lab somewhere in your community so that you have a place to refer patients for imaging, and maybe even x-rays. In my 40 years of practice, for the first 36 of them, I had my own x-ray unit, and we had a good one, and we were able to take good diagnostic quality x-rays. But when I moved my office 4 years ago, I did not want the expense of a good quality digital x-ray machine, which can vary in price range from $50,000 to $90,000, just depending on the company and the quality. Just did not want to incur that expense, so we hooked up with a local imaging lab, and it was one of the best decisions that I ever made. Number one, I became good friends with the radiologist, and number two, I get a radiology report with every patient that I send for x-rays. And number three, the quality of the x-rays, and of course MRIs or anything else we send is ultra high hospital grade quality. So you'll have to decide what you want to do when you get in practice, whether you want to take your own or send them out. For me, the biggest advantage of sending them out is a board certified radiology report so that I know I am not missing anything on the patient. Once the patient begins to respond at the 50% improvement point, we then reduce the care of the patient from daily to every other day. And we continue on that reduced frequency basis every time the patient is subjectively and objectively improved by another 50% until we work them out of the office or onto some type of maintenance care. It's about a 90-day journey, somewhere in that range. The quintessential clinical finding for referral or sharing the case out or getting assistance or co-managing the case is progressive deterioration of motor function. We must watch the motor system. You've got to, on a weekly basis, check your positive findings, and certainly if you had a diminished reflex, it must be checked weekly. If there appears to be atrophy, you've got to be measuring it weekly. If there's any myotogenous weakness, in other words, maybe the S1 myotome, which controls plantar flexion, and your gastrocs and your soleus, maybe that was weak. You've got to check those muscles and make sure that they're not getting worse. It's actually a win in the beginning if they're just stable. They might not be any better, but they're not any worse. So the case is stable and you continue to treat. If you see them begin to deteriorate, don't stop treatment. Just send them for a referral and maybe the assistance of some medication to enhance healing. Another patient management tip. This is based on a study done in the late 70s, and this was repeated again in the 90s. I don't have that one listed. But this was done on volunteer medical students who enabled the researchers to put a pressure-sensitive transducer, that's basically a needle, into the nucleus pulposus of their third lumbar discs. And then they had these students assume the positions that you see in the chart here. And what they discovered is that intervertebral disc pressure varies from 25 millimeters mercury all the way up to 275 millimeters mercury. Now, the thing that we want you to take away from this, if you'll take a look here, when you're laying on your back, intradiscal pressure is at its lowest point. When you're laying on your side, it triples, but it's still at a fairly low point. When you sit, which is what a lot of patients want to do, it goes up to 140. And so the whole point of this study is to encourage the patient not to sit, but to lay recumbent, to lay supine or recumbent. A lot of them will tell you that I cannot sit. It causes too much pain, which of course matches the research in this study. All right, and then we have a study that was done by Dr. Cox on patients with chronic buttock pain after much of the back and the sciatic leg pain has been alleviated. And he found that in many cases there were some stubborn trigger points in the gemelli muscles, or even in the obturator internus. So he came up with what we call the GOIC syndrome, the gemelli obturator internus complex, right? And so you can see the muscles there. Here's a better view of them. We've got, of course, the piriformis right there. We have the quadriceps femoris there. Then we have the obturator internus. And then we have the superior and the inferior gemelli muscles. And that's where the GOIC complex comes from. So what you would do is you find the greater trochanter, you palpate and you find the greater trochanter, and then with your thumb, you just go medial until you kind of fall off of the trochanter, and you'll be on the gemelli muscles and the obturator internus muscle, and you just feel for trigger points and just gently rub them out. And Dr. Cox, and I would concur, is people will say, they've got a deep ache in their buttock, or what he calls a toothache in the buttock, and oftentimes if you'll examine, you'll find trigger points, and if you gently rub them out, the patient will get the relief that they're looking for. Ending the adjustment session. So there is a video that goes over the first two. I think you're familiar with number 3. It is really important that before you even get the patient on the table, you ask them, how long did it take you to get out of bed this morning? Because we use that as a barometer for how long it's going to take them to get off the table. After you treat them, trust me, they're just not going to spring up off of that table and go, woohoo, I'm all better. I wish that were the case, but disc cases just don't respond that way. So you ask them, how long did it take you to get out of bed, Joe? Oh man, doc, oh, it was rough getting out of bed. I think it took me 10 or 15 minutes. I tried this way, I tried that way, and I finally got up. All right, so tell them, say, Joe, we're going to get you down on the table, but I need to warn you, when you try and get off the table, you're going to have the same difficulty that you did getting out of bed. I wish we can get you quick relief, but with your condition, it's just not going to happen. And when you've laid on your stomach for 30, 45 minutes, which is going to encompass the treatment time, you're going to have some difficulty getting up. So we want to show you how to get up. All right, so you would actually demonstrate these for the patient before they got down. All right, so some things to consider is you adjust the table height to the patient's preference. You secure the caudal section, make sure it is not loose. Make sure the caudal section brake is engaged. And the same thing for the lateral flexion lever. And those are all, we go over those in the videos. Fully lower the tiller bar. They do not need to wrestle with the tiller bar trying to get their feet over it. Make sure if the cuffs were on that they're removed, and then offer to assist the patient. Some of them want help, some of them don't want help. The problem with helping a patient is sometimes you move them too quickly in the wrong direction and they get a twinge of pain. So if you're going to help them, just move at their speed. Or if you've got a busy practice, have the patient's significant other or your CA help the patient. All right, so you've got descriptions that you can read over for 3 ways to get off the table, and then there is a video that will go over the first 2, and again the third one I'm pretty confident that you have seen or maybe even done before, but very simply you set the table height so that if the patient were to sit up, they would have both feet on the floor. Then you just instruct the patient to turn fully on their side and to pick the side that's most comfortable for them. And you can ask them, in bed last night, Joe, what side was it easiest to lay on? They'll say, well, it was my left side, doc. Okay, Joe, so we're going to have you turn on your left side. All right, and once they're fully on their left side, then kind of show them how they can use their hands, their arms, and their elbows to raise themselves into a seated posture. And then once they're in a seated posture, then they can begin to stand. So that's your third way.